Hello everyone and welcome to today's webinar brought to you by the ophthalmologist and ODOS. I'm Phaedra Pavlou, Editorial Director of the Ophthalmologist, and I'm very pleased to be moderating today's event on targeting central serous chorioretinopathy, or CSCR, with navigated laser. I'd like to welcome our speaker, Dr. David Brown, and to say a few words about him. David graduated from Baylor College of Medicine with highest honors and completed ophthalmology and retina training at the University of Iowa, where, among several accolades, he was awarded the Ron Mitchell's Fellowship Award, which is presented to the top retina surgery fellow in the US. David is a world-renowned thought leader and on the research and treatment of age-related macular degeneration, diabetic retinopathy, and retinal vein occlusion. An elected member of the Macular Society and the Retina Society and serving on the board of directors of the ASRS, David is the recipient of many major honors, including the AAO Senior Achievement Award, the ASRS Senior Honor Award, and he's been continuously elected one of the best doctors in America, as well as a Texas Superdoc. David serves as the director of the Greater Houston Retina Research Center and is clinical professor of ophthalmology at Baylor College of Medicine. He has written and published over 300 scientific papers, including many of the primary papers establishing the current standards of care for AMD, retinal vein occlusion, and diabetic retinopathy. It's our great pleasure to have you here today with us, David. David will be available to answer your questions at the end of this webinar, but please know that you can submit your questions at any time throughout the webinar presentation by clicking the Ask a Question button. So I encourage you to do so. We also have some polling questions for you to answer before we get the presentation underway, and also after the presentation, so please do take part. I'll kick us off with our very first two polling questions. We would like to know, which technology are you currently using for CSCR treatment? PDT, laser, or none of the above? Again, which technology are you currently using for CSCR treatment? Please select either PDT, laser, or none of the above. Great, thank you. And second, can you please tell us how many CSCR treatments does your clinic perform each week in total? You should see a free text box there for you to enter a number. So if you could just tell us, how many CSCR treatments does your clinic perform per week in total? Great. Thank you so much. Okay, so without further ado, let's get today's webinar underway. David, over to you.
Hi, this is David M. Brown. I'm a retina surgeon and retina consultant of Houston in Houston, Texas. Today we're going to talk about using the Navilas system for central serous chorioretinopathy and our experience here in Texas, both from different methods to treat the disease and in specifics how we use the Navilas laser-guided system. First, what is central serous chorioretinopathy? We used to call it CSR, central serous retinopathy, but we subsequently noted it's predominantly a disease of the choroid. It's a major cause of vision threat in middle-aged adults, particularly men, characterized by serous limited detachments of the neurosensory retina. We used to say it was unknown cause, but most of us think we have a pretty good idea now, and I'm going to go into that. As you'll see, the incidence is about 10 per 100,000 men and about 2 per 100,000 women. And that comes from a paper from 2015. So the risk factors are predominantly, we used to say all these things about endocrine changes, type A personality, gastrophysiological disorders, all this stuff. Turns out most of that's just kind of true and unrelated. The biggest reason people get central serous chorioretinopathy is that the retina is not stuck to the back of the eye, it's sucked on by a pump. And a certain percentage of the population is born with a really good choroid or a really good blood supply. And if you have a really thick blood supply, it's easy to overwhelm the pump. Here you have, that's actually on the large end of normal. That's one of the medical students that helped provide our slides, normal there. The average choroidal thickness is 2/3 the thickness of the retina, or about 200 microns. The choroid, as you see on the right, those 700, 800 microns, that's the perfect setup for CSC. What are the things in the first slide have to do with this? In other words, glucocortisone use, whether it's Flonase for allergies, or whether it's a cortisone shot in your knee, or chronic steroids for Crohn's disease, those all increase vascular leakage. What about stress? We all talk about stress and type A personalities. And that's because in stress, the body makes cortisol, which again, a glucocorticoid that increases vascular leakage. That predisposes people with a thick choroid to develop this blister of fluid that's often self-limited. And in those cases, most of us don't treat. If it's a one-time episode and goes away in a week or two, those are the ones that make the studies difficult, because if you take a lot of patients, some of them do fine with no treatment. However, a lot of these don't go away, partly because they keep taking their steroids or their underlying choroid just doesn't allow for the pump to dry out the retina. So a thick choroid, there's strong evidence supporting the principal underlying mechanisms of the choroid, really first noted by Rick Spade and others, leads to the PEDs. You can get both PEDs and subretinal fluid. We've actually done treatments for both PEDs and subretinal fluid. Usually we wait till there's subretinal fluid. Inamura, which is with Rick Spade, found eyes with CSR, have choroids 214 microns thicker in thickness than age-matched controls. So another entity is pachychoroid pigment epitheliopathy, first described by Bailey Freund and his groups. And what that is, after you have CSC and the fluid resolves, you often get pigment changes that in an older patient can look like age-related macular degeneration. If, however, you've got a thick choroid and we think it's old CSC, we call it pachychoroid, root word Latin, pachy, like an elephant, or large, pigment epitheliopathy, and that's a precursor to CSC. Other papers have been presented to demonstrate that if you look at fellow eyes with CSC, almost all of them have a thick choroid as well. Why is it mainly younger patients with CSC? It's because with age, everyone's choroid thins, and so you basically outgrow it after a while. Although we certainly see 70-year-old patients, as I'm going to present in the end of the webinar, who can present with CSC, misdiagnosed as AMD. But it's the CSC treatments that treat them, as anti-VEGF does not work for CSC routinely. OCT is how we diagnose all this stuff. You see the subretinal fluid, the patient complains of micropsia, a hyperopic shift. You see subretinal fluid, and in many patients you see a pigment epithelial detachment. Fluorescein angiogram is often helpful. It often shows a pinpoint leak in the RPE. This is a classic smokestack. You don't see that very often. You see it, less than 5% of the time. But if it's a very fast leak, it will fill that serous retinal detachment with fluid rise to the top, giving you the classic mushroom cloud. The reason this is very helpful, and one of the reasons that makes Navilas the ideal treatment, is it's often there's no clinical correlation in the fundus, and so that little hot point leak is just a place in the RPE that's pretty hard to figure out where it is unless you're treating off a fluorescein angiogram like you do with the Navilas. Fundus autofluorescence can also give you clues. This shows guttering, in other words, evidence of old RPE damage from chronic fluid going inferiorly. If you see this, even without fluid, you know that they've had bad central serous at some point. ICG is also often helpful. ICG often shows you massive engorgement of the choroidal vessels. Can also show you hot spots. Polypoidal choroidopathy is in the same spectrum. And many of these patients with pachychoroid that are prone to CSC can develop polypoidal later in life. Subtypes, these are all defined, and we really care about acute and persistent, and that's really dependent on their career. You know, patients that are airline pilots, and I treat a lot of United pilots here in Houston. Maybe it's just stress, and who knows what it is, but we see a lot of CSC patients with that are airplane pilots. They obviously want to get treated and have a quicker duration. They can't take off flying until it goes better, and actually they have to be free of disease for a month or two before the FAA will let them fly. Treatment, a lot of people just wait. Resolves in itself in 3 to 4 months. Personally, I'm too impatient to wait that long, and most of my patients. I will often give patients a month to get better, but if they're not better, we start talking about treatment regimens unless they're totally asymptomatic. The treatment regimens, and we're going to go over, are conventional laser photocoagulation. I say conventional, but with the Navilas, it makes it really a totally different ballgame in my opinion. PDT is a very effective method for treating for treating CSC. How does it work? It thins the choroid, so it actually treats the underlying thick choroid. The problem with PDT is that the drug's $1,400 to $2,000 a dose. And very few insurers, there's a couple that are paying for it now, but a lot of insurers do not cover CSC, as it was never FDA approved for that purpose. One additional problem with the photodynamic therapy is there's less and less lasers out there. PDT lasers are uncommon, and as they break down, more and more people don't have them. I think there's probably more Navilas lasers than PDT lasers in parts of the country. Another option is subthreshold micropulse diode laser. Again, the Navilas really shines in this regard. There's a lot of variability in how people are using parameters, and we can talk about this. But that's one way to treat, say, a subfoveal lesion that you really wouldn't want to treat with conventional photocoagulation, or a broader area of diffuse ooze. Lastly, would be remiss to not talk about pharmacological therapy. Eplerenone, an anticorticosteroid drug, and the abortifacient agents, mifepristone, both can work. It's the last drug's really hard to get and really expensive. Eplerenone, a lot of my partners use it. I don't use it very much. To be honest, I'd rather treat an ocular condition with a pure ocular treatment as opposed to something that can affect their whole body. What about the Navilas laser, what we're talking about today? It gives you pre-planned, computer-guided, digitally documented treatments performed by the Retina guy. It's safe and effective in CSC. To be honest, I think this is where CSC is one of the diseases that where the Navilas laser really shines and makes a big difference in your treatment outcomes. I'm going to show you some of what happens, the Navilas workflow. There is digital fundus imaging, and you can either put an OCT overlay or a color fundus overlay or a fundus fluorescein angiogram. You digitally plan on this, and then it uses an eye tracker and allows targeted assisted laser treatment. You put no-fly zones in areas where you don't want, the nerve and the fovea, for example, and then followed by the treatment, which is pre-programmed by yourself. You still have to put your foot on the foot pedal, and you can take your foot off the foot pedal. A lot of times at first my doctors are pretty nervous. Is this thing really going to fire in the right place? Because the patient doesn't have a contact lens on and is moving around. But the laser does an amazing job of pinpointing your treatment to exactly where you want it. Here you see an example in CSC where you're looking at the exact hot spots from the fluorescein. You've pre-planned your no-fly zone. Here the eye's tracking. You actually learn to be a little bit of a photographer yourself. The Retina guys, a lot of us didn't do that before. And then, again, another plan. These are me doing lasers. And as you can see, many of mine, I'm looking at 2 spots, and I've done quite a few patients. 1 spot, exactly the right place. The patient goes, "That's it?" "Yep, that's it." And we're going to show you our results with fluorescein-guided focal treatment of CSC here in my clinic. Here we looked at the last 50 consecutive patients I had treated with the Navilas focal laser. The mean age is 48 years old, range from 32 to 76, so don't forget about old people. Just because you're old, you can have a thick cord and you can get CSC. We were 77% male, and we had more right eyes than left eyes. A few of these, so 13% were smokers. The majority were phakic, and the mean ETDRS letter score was 70.9, which is pretty good. Mean central thickness, though, was 397. A lot of these had a lot of fluid. This just shows you the chronicity. And if you're looking at the majority of my patients that had CSC for over a year before either they were referred to me in our tertiary care referral or they finally got around to doctor shopping to look for different treatments. Many were at that 100 to 500 days, but some are less than 10 days. And the majority of those are my truck drivers, my airplane pilots. A lot of those are a fellow eye, but they said, "Hey, I want to get this treated to make it go away faster." And I think the focal laser to a hotspot leak well outside the fovea is a reasonable risk-benefit ratio for getting them back to work and functioning. Here you have some more evidence of how I did. The power is pretty low. You're looking at 100 to 130 milliwatts. I do like a gray-white burn for these focal treatments, not hot. Pulse duration in milliseconds, typically 100. Spot size, most of them I'm at 100 microns, but some I'll enlarge it. If the spot's a bigger spot on the fluorescein, I'll want to treat the whole area, and I'll up the power at that point. Here you see the number of shots. My mean number of shots is 6.11, and that's because I started at a low power and I up it. A few of those are air balls. I mean, a few of those, I guess, are sub-threshold treatment, but I like to go to get a full threshold treatment on these spots because they're typically not fovea. I will go juxtafoveal, but I won't go subfoveal. Single, 88% had a single treatment. Some had more than one treatment. A couple of patients had to have up to 5. They kept getting different leaks, but I'd chase them around and eventually get it. Here you have our the mean duration. We're cutting up this data a million different ways. But bottom line, change in central thickness was clinically significant in our 10 to 100-day group and our over 500-day group, and was certainly a trend with our other groups. And our change in visual acuity, both positive as well as our improvements in subfoveal thickness. Proof of the pudding, though, is in how many patients you actually dry out. And by 4 months, we had dried out 76% of patients with one treatment. And if you look down to multiple treatments, we're down to 84%, totally resolved, and that's fluid anywhere. Mean baseline visual acuity was 71 letters and had a couple letters improvement. Many of those patients, though, with a hyperopic shift see pretty good, but they note that distortion and micropsia. Let's look at other studies. Our results are not as high. And maybe I'm not as good, or maybe it's because I look at every scan and we're calling any little bit of fluid positive for subretinal fluid. For most patients, the fovea dries out pretty quickly, and they really prefer it than taking Eplerone, which is a pill they have to take all the time. The results, though, are very good overall, with some centers reporting up to 100% success, 100% resorption. Again, if you notice ours, we had a lot of patients over 500 days, so we had pretty chronic treatments. Just giving you a case, here's a patient with a refractive CSC. They've had a duration for many months. This is from Dr. Zhou in Berlin. When I visited her, she had 8 or 10 to treat the same day, so I think she treats a lot of patients there in the Berlin hospital with CSC. Here you are, one shot, and it works. Here's another case from the same clinic. Here you see subretinal fluid and a PED, and you see resolution by week 4 of the subretinal fluid and by week 12 of the PED. And so you can, here she's, some of those spots are pretty close to the fovea, but with the Navilas, you're comfortable treating those, knowing that there won't be an error and it's not going to hit a subfoveal burn. Here's a case of mine showing you a typical case, and this is a guy treated his other eye last year and this eye just a few months ago, and I saw him back this week, so I thought I'd show him to you. He's a gentleman with a monster area of subretinal fluid. If you look, he's 72 or 73 years old, 76, I'm sorry. 76 years old, and he'd been told he had macular degeneration and his injections didn't help. Came to see me, and with that thick choroid and the clinical appearance, it sure looked like CSC to me, except for in the fluorescein, which had focal hot spots leak with no evidence of CNV. I treated this eye with the Navilas guided laser, and improved from 730 microns to 657 to 440. Well, here you go. I treated a couple more hot spots, showed back up, and retreated them. And I had to keep beating on this eye. This is the guy with the most treatments in our series. Told me it always doesn't work, but finally dried him out. And then in the left eye, got subretinal fluid that we were treating with 2 little spots, and totally dried it out. So use this. He didn't want to go on pills. He takes pills for other things and didn't want to go that route. And I think it was the perfect treatment with Navilas guided laser. Again, resolution. Here we are finally with resolution in that with the big subretinal fluid with resolution when I saw him yesterday. What about subthreshold micropulse? And there's a bunch of different names for this. I'm using subthreshold micropulse because most people call it either subthreshold therapy or micropulse. I think it's intriguing. If you look at it, there's increasing number of literature on PubMed, a lot more interest in subthreshold micropulse. I was very skeptical of subthreshold micropulse until the Navilas. What I like about the Navilas is with the laser guiding, you know that you're getting the grid in the same place. If the eye moves a little bit with a non-guided laser, you're basically not doing subthreshold anymore because you're getting multiple hits over the same area. Principles of subretinal micropulse can be argued, but in theory it allows tissue cooling down to avoid reaching coagulation threshold. And that temperature increase is thought to change modifying factors, which in diabetic retinopathy and others can lead to changes in different cytokines. The key challenges are visualization of the lesion and making sure you're not retreating over it and correct coverage. Really, the only way to potentially do this is with the Navilas guided therapy. A third problem is optimal parameter sets, and I have a lot of good friends that do this, from Rich Rosen to Victor Chong, and they all do it differently. And so you kind of have to figure out who you trust and go from there. Here you have a treatment process, transparent. Here you're doing the plan. The plan, you're figuring out an area. To me, the best areas are either ones that you're too afraid to treat with, a true gray burn, a focal laser, like something that's very near the fovea, or a big diffuse ooze. That's really where we use it the most. We really don't see focal hotspots. A lot of these chronic CSCRs, you see that. The surgeon's independent, can exact execution of the plan. You have to push the foot pedal down or it doesn't go. So here you see treating an area pretty close to the fovea, but notice how the patient's eye's moving, but you're still treating that area without hitting repeat treatment. That's the true advantage of the Navilas in this subthreshold micropulse treatments. And then it gives you extensive documentation with a retreatment option, so you can come back later and either treat that same area with a higher intensity or go to a separate area, avoiding that altogether. Got a bunch of studies, prospective studies. Here's one with 10 eyes, subfoveal leakage. These people have more guts than I do. I'm typically not treating subfoveal anything other than with laser. I think our comfort level is getting better. But here you have patients that had subfoveal CSC leakage, and with some treatments right at the fovea, or just right where most of us would be scared to treat. However, with the confidence in the Navilas that you are treating subthreshold, that's what this paper was about. Retinal sensitivity statistically improved after this treatment. It's 10 eyes, so small sample size, but central thickness also statistically improved. Here's just a case presentation. Here's a chronic CSC with subfoveal leakage. Here you see that leak is right in the fovea. They're using 100 milliseconds with a 5% duty cycle at 30% power. Different people do it differently. Some people do a treatment until they get a visible spot somewhere outside the fovea and then go down to 30%. But there's different, you can talk to Rich Rosen or Victor Chong or others to figure out where you want to start. Most of us would recommend starting lower than you kind of think, and then up your power, knowing that you may have some treatments that aren't working, but you certainly don't want to overtreat in something like this subfoveal treatments.
Yeah, probably me.
Here's a second case, recurrent CSC with subfoveal leakage. Here you have a treatment right pretty close to the fovea. They did note you have to put the no-fly zones on so that it doesn't turn off the overlay all the time. And so they kind of move the no-fly zone of the fovea slightly out of the way. Our colleagues in Munich with a nice resolution of fluid, and this patient with CSC, and a treatment that's really right at the fovea, if not right there. Third case, recurrent CSC with subfoveal leakage. Here they're treating multiple different areas. They did a confluent grid, 100 micron spots covering leakage. They did it actually off the OCT scan, wanted to hit the areas of the most leakage. 1 month post-laser, you have improvement in the fluid, and by 4 months, significant reduction with vision improvements to 20/20. So they were 20/20 at the beginning, but they had a lot more distortion, I would bet, than at the finish. So what about subthreshold micropulse laser as an alternative? You know that the Epleron I'm not a big fan on. PDT I do like, but like I said, a lot of patients have hard time getting the drug, and the laser is expensive. You also run the risk with choroidal thickening that with age you're going to want that choroid. We all know that age-related choroidal atrophy can be a problem, and so most of us would rather not give up choroid if we didn't have to. So for me, the focal laser to a hot spot is my first treatment. But my second treatment is to consider subthreshold micropulse versus the Epleron, or for those with a really big choroid where they can get PDT, considering half dose or half fluence PDT. This is peer-reviewed publications comparing PDT and subthreshold micropulse. Note that most of these aren't randomized; they're consecutive case series. They go as well as the PDT winning 67% to 28% resolution, to on the flip side having a 22% resolution with PDT and 59% with subthreshold micropulse. But as you note, the parameters, everybody does it different, and maybe you want to look at the parameters that do better, or work with yourself to figure out what your comfort level is with parameters of subthreshold micropulse. So in summary, we've gone over a lot today. We've gone over what CSC is, why I think it's predominantly a choroid disease, how my first line of treatment is, as in the 50 eyes I did, the focal laser to a hotspot leak outside the fovea, but consider subthreshold micropulse, and those with the diffuse ooze are further out. Why use the Navilas for both of those treatments? Finding that focal hotspot, it is amazingly easy and amazingly safe with the Navilas. Same thing if you do use subthreshold micropulse. I think the Navilas is your only safe way to do it, where you're not potentially hitting the same spot multiple times as the eye moves, and that you can retreat in areas and know exactly where you've treated. The eye tracking makes you give more comfort, and the patients like it better as well. And lastly, just kind of a take-home points of where we are. Focal laser first. Consider PDT. Oral medications, and those who don't want laser, or ones my partners use them a lot. I don't use them as much. And certainly, subthreshold micropulse is increasing in popularity, and the roles are expanding. And so, I personally use them only for cases with diffuse oozing and no defined focal leak, or large extrafoveal areas of fluid. But I think that's expanding, and maybe I'll be among the subfoveal treaters one of these days, but I'm not there yet. These are references. Certainly, there's millions, and not millions, but lots of references now for subthreshold micropulse. I would particularly tell you to use the ones that are Navilas based. I think it's a lot more reproducible and a lot safer way to go. And I welcome any questions at the end of this webinar. Thank you very much.
Many thanks for your excellent presentation, David. That was great. So we're almost ready to open up our Q&A session. Thank you so much to those audience members who have already submitted questions to us. We will get through as many as we possibly can in the time we have available. But if anybody else would like to submit a question to Dr. Brown today, then please do so. Any questions that are not answered live today will be answered after the event has taken place by email. But I'd encourage you to keep those questions coming in today. To those of you in the audience, I have one final polling question before we go to the Q&A with Dr. Brown. We would like you to answer the following question. If you can answer yes or no to the following. Are you currently using a microsecond or subthreshold laser for CSCR, DME, or any other indications? Please answer yes or no. Again, are you currently using either microsecond or subthreshold laser for CSCR, DME, or any other indications? So if you can just hit yes or no. Perfect. Thank you. Thank you so very much. We're now ready to get the questions and answer session started. Again, please feel free to submit as we go. Right, Dr. Brown, first question for you. What's the time required for CSCR treatment with the Navilas?
So the Navilas, especially for CSC treatment, is very quick. We typically do a fluorescein angiogram, typically on the Heidelberg, import it into the Navilas. With the Heidelberg, if it's in the macula, the tracking, in other words, putting the images together, literally usually goes automatic without any input. Then, especially with CSC, where you have 1, 2, maybe 3 little spots you're hitting, takes me 10, 15 seconds at the most to line up what I want to treat, and then I'm ready to go. Then I have the patient put their head into the system, and you just focus, and once you're auto-focused on the retina, it's automatically focused. You obviously want to put your no-fly zones, your don't attack, because that allows it to not have the tracking go off all the time. That takes seconds. And then the treatment itself is often 1 to 3 spots. And so it's super quick. The patient goes, really? That's all it was?
Great. I mean, you spoke there about aiming, Dr. Brown, and with regards to aiming, since you don't have a stereoscopic view or depth of field, is it problematic?
No, I mean that's one of the beauties of the Navilas itself. If you've got a good image of the retina, it automatically focuses depth in terms of the laser. It does some autofocus for you. I'm not a photographer, and my photographer makes fun of me all the time because he thinks he'd be better at it than me. But I'm getting pretty darn good at getting the patient images logged up and going. It hasn't been a problem either with CSC, diabetes treatments, or otherwise. It's amazing how it works. There's no contact lens on the eye. The patients can blink. Patients can move around. It tracks amazingly well.
Perfect, thank you. And we have one of our audience members asking about automatic patient reporting. How often do you use the automatic patient report in reviewing your CSCR?
To be honest, I don't. We do. It's in the system. If you want to pull it up, you saw some of our data when we presented when we looked at our, past case series of CSC treated with focal Navilas. It was great. You could pull up exactly the treatment paradigms, exactly where I treated. You could see the powers used. It saves all that in the system. You could certainly print it or import it to your software if you wanted to. I assume my techs are either importing or writing it down, but that's not what I do. I see the patients and documentation happens. It's almost like magic.
Great, thanks. And somebody else is asking about melatonin. Do you have experience of using melatonin in CSCR?
Not at all. I mean, I can tell you the thing about CSC or CSCR, whatever you want to call it, a lot of it's self-limited, and a lot of patients do better with nothing. And so if you look at PubMed and do literature searches, you can find that everything works because if something's self-limited, often things get better. Melatonin might work by making people chill out, right? They might get better sleep and have less stress and less cortisol production. I guess that would be the mechanism. That goes into some of my partners use Eplerone, some of the other systemic drugs. I really don't like using a systemic drug for an ocular problem. To me, a quick focal laser to the hot spot, especially with the Navilas, where I'm confident that it's going to be placed exactly where I want it to, and they're not going to, saccade off and I accidentally put the spot in the wrong place. To me, it's much safer and easier. And it's also, I don't have to worry about systemic management of their, with melatonin, you wouldn't have to worry about it, but certainly the others, you need to worry about some of their systemic electrolyte issues, et cetera.
Yeah, okay, great, thank you. Somebody's asking about your experience of focal CSR leak due to a dysfunctional RPE or mechanical microgap in the RPE layer. Do you have any comments or experience in that regard?
To be honest, we knew nothing about CSC until we got better resolution of the choroid with enhanced depth imaging OCT. What we found out is that everybody with OCT, everybody with CSC has a thick choroid. And we know that the retina is not stuck at the back of the eye, it's sucked on by a pump, and our hypothesis is those with a big juicy choroid, it overwhelms the pump. It probably overwhelms the pump focally, and that's why you have a focal leak with sometimes a smokestack on the fluorescein. How the mechanism of laser works, we really don't know, but we assume it's irritating or changing the polarity in that pump area with the little focal laser. But the microgap junctions, you'd have to have really a good animal model of CSC, which we don't have, or be lucky enough to get electron microscopy of somebody that died instantly with the problem, I guess. But it's interesting. We really don't know how laser works. It certainly works for this indication. It certainly works to close focal microaneurysms in diabetes.
Okay, thank you. And the question on fluorescein angiography, is that the best image to localize the leakage, or do you combine with other ones?
You know, once you've done this for a while, a lot of times you can see that little focal PED on the OCT. I do it with the fluorescein because it gives you fantastic tracking with the vessels. You can get it though with the near-infrared reflectance of the, on the Heidelberg spectralis. You could do it that way. We do it with fluorescein. To me, you see a lot more leaks. You know, in the OCT, I'll see one little spot that's often the leak if you track it on the fluorescein. But with the Navilas, there'll often be another couple of leaks that are maybe just leaking a little bit, and I'm totally comfortable hitting all three. It takes an extra 2 seconds, and what I want to do is to have the fluid go away as quickly as possible by changing that pump dynamics.
Great. And what's the health of the RPE at laser, kind of the laser hit points?
Because you're hitting so focally, it's more like a stealth missile. You know, you're not hitting a bunch of areas of RPE that you don't want to hit while you're trying to figure out where the leak is. I think that's the biggest game changer with the Navilas for CSC treatment. With the traditional laser, you don't have landmarks other than the vessels. You're kind of extrapolating your view of the fluorescein back to the eye, inverting it with the lens. You're hitting a lot of real estate that doesn't need to be hit. With the Navilas, you are putting a targeted missile strike with minimal laser power directly to where you need it. It is often one spot. And if I want a light gray burn on focal laser that's not subthreshold. I don't want a big hot white spot. And so if I get nothing, I up it. So occasionally there's an air ball or two adjusting the power up, but there's not misdirected laser spots like you have almost always with traditional laser that doesn't track or is not guided by fluorescein angiography.
Perfect. Thank you so much. And we've got time for just one final question, if I may. So question has come in about changing your treatment choices, specifically PDT or a plenarone. When would you favor either of those options in your patients?
So Rick Spade, as far as I know, is the first guy started using PDT for CSC. He did it in very chronic patients, had a lot of anatomic successes without much visual acuity success. Rick and I are good friends. We brainstormed potentially after a cocktail or two and decided maybe we should use lower dose. I started using half dose or half fluence PDT way before it was cool, probably, gosh, I'm showing my age here, but probably 2001. So been using PDT for CSC for that long. We presented it first at, I believe at ARVO at a poster. We got scooped by a Japanese group that did a big number. So we didn't even publish our results, mainly because it worked well and patients didn't come back. Biggest problem with PDT is insurance companies didn't want to pay for it, and it was $1,500 a dose. We didn't have guided Navilas laser. Focal laser was not that effective. I was pretty much a half dose or half fluence PDT guy until I got the Navilas laser. And once I got the Navilas laser, I realized that most of these patients, if you hit the little focal leaks with the Navilas, you resolved, as our data showed, 80 to 85% without treating with PDT. Insurance companies preferred it. It was cheaper. It was quicker. They didn't have to stay out of the sunshine for 48 hours. Patients preferred it. And so now we use PDT rarely. It's mainly for the chronic diffuse leaks. That's sort of also where you'd try micropulse subthreshold laser, which is a little bit more variable on trying to get your dosing. PDT works. PDT works by killing the choroid. you've got an indication with too much choroid, too thick of a choroid, you're killing some of it. What you don't want to do is do PDT in somebody with a thin choroid, because that's how you can get vision loss. If they get a thick choroid, I think it's a reasonable alternative. About eplerenone or some of the antagonists of steroids. I prefer not to use that. I don't like systemic medicines if I can help it. If I can treat it just ocularly. Some of my partners use it because cortisol makes blood vessels leak more. If you take steroids, if you take Flonase, if you have a lot of stress and endogenous cortisol, your blood vessels will leak more and predispose you to more CSC. Typically, with one of these blockers, you can alter it a bit, but to me, a lifetime of having to block your cortisol in your body is probably not worth it when I can do a one-time focal Navilas laser and fix you, 8 times out of 10.
It's a perfect way to end this session, Dr. Brown, and thank you so much. That is actually all we've got time for with the Q&A session, but we do have many more questions that have come into us. So I just want to reassure our audience members that those questions will be answered after today. Email responses will be sent to you, and several people have actually asked about getting access to this presentation after today. Just to reassure you, all this webinar will be available on demand. In the next couple of days, you'll receive an email with a link to the on-demand version. You can revisit today's presentation and the topics that have been covered by Dr. Brown, or you could refer it on to a colleague who you also feel may benefit. Also, you should shortly be seeing a link appearing on your screen to a very short survey. It will just simply help us to tailor our webinar content to suit your needs. So we'd really appreciate it if you take just a few moments of your time to complete it right now. I'd now like to offer my sincerest of thanks to our speaker, Dr. Brown, again today. Thank you so much for an excellent presentation and a great Q&A session, Dr. Brown. Thank you very much. And finally, I would like to thank all of our audience members for attending. I look forward to hosting you all at a future webinar. So I'd like to thank you again and say goodbye.